Welcome to UMDF's Ask the Mito Doc monthly webcast. Tonight we will hear from Dr. Amel Cara, UMDF Scientific and Medical Advisory Board Chair, and Dr. Michelangelo Mancuso from Italy's University of Pisa. Our moderator for the Q&A this evening is our very own Margaret Moore, UMDF Associate Director of Support and Education. Let's get started, Margaret.
Welcome, everyone, to our January Ask the Mito Doc webcast, where we're going to learn about primary mitochondrial myopathy, or PMM. We want to get started by thanking our sponsors, Edith L. Trees Charitable Trust and UCB. We can't do it without the help of our generous supporters. Well, let's get started. I'd like to have our speakers join on camera. And I'm going to turn the floor over to Dr. Amel Cara.
Thank you, Margaret, and good afternoon, everyone. I'm delighted to be here today with our esteemed speaker, Dr. Michelangelo Mancuso, who is here from Pisa, Italy. Dr. Mancuso is a professor of neurology. He specializes in cardiovascular, neurological disorders, neuromuscular disorders, and genetic disorders. He does a lot of clinical work. He does clinical research and conducts multiple clinical trials, including in mitochondrial disease. He is the chair of the European Reference Network for a Neuromuscular Disorder, as well as the head of multiple organization of neuromuscular and rare genetic disorders. He is our expert in primary mitochondrial myopathy, and I'm really grateful that he took time out of his busy schedule to talk to us today about primary mitochondrial myopathy. So today's session will be a small, short presentation by Dr. Mancuso, and then he and I are going to talk and answer some questions in the second half of today's presentation. Dr. Mancuso, welcome.
Thank you, Amel, and thank you for the nice invitation for being, I think this is the first time for me that I have a webinar for UMDF, so I'm very happy to be here with my American friends. So as Amel said, I'm working since 20 years now, maybe 24. I don't remember on mitochondrial disease. Actually, I was trained in New York and Billy's DiMauro's lab. So I was always involved in mitochondrial medicine. So today, basically, what I will try to do is to briefly cover, I guess, I hope at least in a very easy way, what is the primary mitochondrial disease, and especially what is primary mitochondrial myopathy. I will provide a few examples. I will try to explain the difference between primary mitochondrial myopathy and primary mitochondrial diseases. And then at the end, I will be available with Amel to take questions and try to answer to all possible doubts and queries and whatever you think I can do to clarify the topic in the best way I can. So when we talk about primary mitochondrial myopathies, we are going to talk about a specific group of mitochondrial disease where the skeletal muscle is the main organ involved. I will give you just to show you a few examples from real life experience. These are two patients that I still following here in Italy, in Pisa. So basically, the first case is an Italian woman of 42 years old that arrived to our attention because she basically had in the past 2 years a progressive droopy eyelid, difficulty of moving the eyes, trouble with swallowing, exercise intolerance, and the muscle pain. So all these symptoms are affecting the muscles, it's very clear here. So she was absolutely fine in the first 40 years of age. She was, actually I can use my laser just to point what I'm saying. So she was fine and until the age of 40. The only thing she was experiencing in the past was mild anxiety disorder. And before coming to my institute, the CK level, the enzyme that reveal possible damage in the skeletal muscle was 243, and normal values are usually considered below 150, 180, depends on the labs. So basically, the patient not only was experiencing all these skeletal muscle problems, but actually also during the neurological evaluation, we have documented that the skeletal muscle of this lady was not performing well. She had this mild proximal weakness, the lower and upper limbs. She also had mild proximal deltoid atrophy. The the facial muscle were also weak, and was clearly also the eyes were involved because we observed this eyelid droppiness and difficulty also in moving the eyes around. And basically, the reflexes, the one that we take with a little hammer as a neurologist, were absent, and the rest of the neurological examination was absolutely normal. So we repeated the several blood tests, including the test that we usually run for myasthenia gravis or for other disorders, included thyroid. We have repeated the CK level, and this time CK and all the other tests were normal. She also performed the brain MRI, which was normal, and we are happy for this. And again, just keep this in mind. If we have a primary mitochondrial myopathy, usually the other organs are not affected at all, independently of the mutation you have in your either mitochondrial DNA or nuclear DNA. The heart was normal, the EMG, the nerves, all the instrumental tests were absolutely normal. So basically, we were facing a sporadic female case from Italy with the, ptosis, ophthalmoparesis, muscle weakness, that started 2 years before without any other neurological or not neurological involvement. So when we see a patient like this as doctors, we have a lot of questions that raise in our mind, So in order to help us in the diagnostic process, we need to focus on the main clinical features, think about the differential diagnosis, and which are the best diagnostic tests we should use in this specific patient, in this specific phenotype, in order to achieve the final diagnosis. Okay. And of course, for us was clearly easy to imagine that the problem was in the neuromuscular system because all symptoms or signs were affecting the neuromuscular system, including the eyelid droppiness, the ophthalmoparesis, the limbogirdle weakness. So for sure, our idea was this is a neuromuscular patient. And then, of course, there are multiple different diseases that you have to imagine, but I don't want to bother you with medical things. So the point is that this is clearly a patient with primary muscular disease. But as you probably know, there are hundreds of different muscular diseases, right? So in order to go through the diagnostic process, we have to do something else. So we didn't observe increased CK values. Usually when you have a muscular dystrophy, for instance, the CK are very high. So we didn't think about a muscular dystrophy. The patient was a sporadic female case. So most likely our impression was that the patient was suffering of a metabolic disorder. So this was a patient that we have analyzed before the revolution of the DNA sequencing and the new technology. So the first thing we did was to perform the muscle biopsy in this lady. Probably if this patient was coming to my clinic in the past 2-3 years, probably we were not going to have a muscle biopsy anymore. But anyway, This was many years ago. And we observed several mitochondrial features in the muscle biopsy, and mainly it's very clearly very clear to see that if you look here where is my laser, you have these white fibers, and these are the COX negative fibers where the reaction for the cytochrome C oxidase is completely absent. And here you have these ragged blue fibers, which are another example of mitochondrial proliferation. But please do not forget that there are two important messages in this slide. Okay, so first of all, as I said, we don't really need always the muscle biopsy, because even without this picture, we now are able to do the genetic confirmation directly from blood, from urine. We don't always need the muscle anymore. And at the same time, there are multiple conditions, including aging, where we can observe in non-mitochondrial patients mitochondrial abnormalities in the muscle. So, I mean, everything must be characterized and put in the good place. And the single test, the single analysis, not always is clearly indicating that you have a mitochondrial disease. So then we did additional genetic test. We found the multiple deletion, and then we went through other analysis. So basically, at the end, this lady is harboring a mutation in this DGUK gene, which may cause a primary mitochondrial myopathy. So the final diagnosis at the end was a primary mitochondrial myopathy caused by mutation in this DGUK gene. So we have closed the circle. And the other case is a 32 Italian man, this time, that came to my attention for an history of exercise intolerance, muscle pain, and this patient, after exercise, not only experienced pain, but he went a few times to the doctor, and they did the blood test, and they found the increased CK level after the exercise. But when the patient rests, at rest, the CK goes back to normal. So this is another sporadic case. There was no family history, no consanguinity. The past medical history was remarkable also in this patient. We went through the usual test and the nerve conduction studies. EMG was normal. The blood tests were all normal. So in this case, we have a classical example of a metabolic disorder that can easily be misdiagnosed, because at rest, the patient is normal. CK at rest may be normal. EMG may be also normal. So when you have in mind a metabolic disorder, a metabolic myopathy, you can, for instance, perform, as in this case, the 4-arm ischemic test, but you can do cardiopulmonary testing, other metabolic exercise test where we can observe, like in our patient, for instance, lactate, that instead of having a specific increment, which is within the normal values if you are not affected by a mitochondrial disease, in this patient, the red line clearly demonstrated that during the exercise, the patient was accumulating more lactate than expected. In this patient, we found the mutation in the cytochrome B, which is one of the genes that are encoded by the mitochondrial DNA. So again, we talk about a very specific group of disorders that was characterized and actually defined not so many years ago. Only in 2016, there was an international consensus defining PMM as a genetically disorder leading to defects in oxidative phosphorylation, which means the genetic defect impaired the ability of the mitochondrion to produce ATP through the oxidative phosphorylation system. And this genetically disorder lead to a metabolic defect that is going to affect predominantly, but not exclusively, the skeletal muscle. So when we talk about PMM, we have in mind a specific group of patients where the genetic defects mainly cause a skeletal muscle involvement, meaning that we don't have brain involvement, we don't have heart involvement, we don't have liver failure, and so on. Because we are considering, because this is a pure myopathic patient, all symptoms or signs reflect an impairment of the skeletal muscle. So you may have all these different symptoms in our patient with PMM. Most of the time, you don't see all these things at the same time. Sometimes, like in my patient with cytochrome B mutation, the symptomatology and the clinical picture is dynamic. It's more present during the exercise. The patient feels better at rest. But most of our PMM patients during the disease course will have fatigue, exercise intolerance, muscle pain, weakness is important, as well as wasting during the disease course. Usually, also the volume of the skeletal muscle got lost. Sometimes you may also observe dysphagia, difficulty on swallowing. Sometimes you have spasm. And another important, which is sometimes a tricky event, is the presence of this myoglobinuria, meaning that during usually an exercise, because the skeletal muscle is not working properly, because the mitochondria are not working properly, sometimes during the exercise, you may have an acute failure of the skeletal muscle, and so the muscle breaks, and you release myoglobinuria, which can cause renal failure sometimes in some patients. But most importantly, I would say most of our patients during the disease course will develop ptosis and also ophthalmoparesis. Actually, when we talk about PMM, what we commonly observe in clinical practice, we observe usually three different, I would say, phenotypes. Because most of our patients are affected by PO, progressive external ophthalmoplegia, meaning that we have impairment of the, we have this ptosis, we have the impairment of the movement of the eyes leading to ophthalmoparesis. But sometimes progressive external ophthalmoplegia is isolated. You don't have any other skeletal muscle involvement. Most of the time you have PO plus limb girdle and other muscles involved. And more rarely, we may have mitochondrial myopathy without CPO, chronic progressive external ophthalmoplegia is another way to define PO. So basically, most of the time we have PO with or without other muscles involvement, but more rarely, we may also have a pure mitochondrial myopathy without CPO. When we talk about CPO, as I said, is the most common phenotype. What we have, as I said, we have this bilateral eyelid droppiness, which is commonly the presenting symptom in PMM, which can be associated with a compensatory frontalis muscle contraction, to help the vision somehow, and in most severe cases, also tilting of the head. So you can use a small amount of vision that remains because of the ptosis to see around. Droppiness is frequently associated with this slowly progressive limitation of the eye movement, which is what we define as ophthalmoplegia. But differently from other disease, mainly myasthenia gravis, usually this ophthalmoparesis is not associated with diplopia. Diplopia may be observed, but it is much more rare in PMM compared to myasthenia gravis, for instance. It is very useful hint in the differential diagnosis for doctors. As I said, with PO is associated with other skeletal muscle involvement. We call this disorder PO and mitochondrial myopathy. We may have this limb weakness. We may observe, as I said, dysphagia, but also respiratory failure may be observed in our patients. Distal muscle weakness, I would say, is quite rare in PMM, is more commonly observed in other muscular disorders, mainly dystrophic diseases. So another chapter of medicine. But from a genetic point of view, here I don't want to bother you, but the message is that theoretically, all possible mitochondrial DNA mutations, all possible nuclear DNA mutations are associated with PMM. You can have PMM if you have a single deletion in the mitochondrial DNA, which usually is not inherited, but you may have PMM also caused by mutation that most of the time patients have in mind as causing MELAS or MERF phenotype. So the 3243 mutation may cause MELAS, which is going to be a completely different disease. If you have a PMM, you can have, as the etiological primum moments, you can have the 3243 point mutation causing PMM, no MELAS. And the same is true for the 8344. Sometimes it causes MERF, but sometimes it can also cause PMM. And in genes, we have so many nuclear DNA encoded genes able to cause a PMM. In this case, the inheritance will be a Mendelian inheritance. Most of the time in the adult population, it will be autosomal dominant for twin color NT1, but also recessive, mainly with POG. Very briefly, PMM usually is a very common manifestation of mitochondrial disease, mainly in the adults. But we also have infantile and juvenile presentation of PMM. And this is much more rare compared to the adult PMM. And when it is manifest in the very early age of life, it can be linked to floppy infant syndrome, severe hypotonia, severe respiratory insufficiency. And one of these forms is caused by the TK2 gene, which is one of the genes where we are now going to have most likely a very efficient treatment in the very next few months. So when we deal with PMM, here is Sherlock Holmes with this journey, diagnostic journey. It's not easy at all to have to make this diagnosis because, as I said, sometimes the disease is only driven by exercise. Sometimes the disease may be confounded with other non-mitochondrial disease, with other metabolic disorders. So it can be very challenging. As a doctor working mitochondrial disease arena, these are my suggestions that I always give to the young doctors or to the non-experts in mitochondrial medicine. Sometimes you may have mitochondrial DNA transmission of the disease, so you should, but also Mendelian inheritance of the disease. So we must absolutely investigate the family history because many times we found that this is not the only case in the family. And so we can, if we explore the family, we can define a pattern of inheritance, which can help us in the diagnosis. Okay. Of course, the blood and the other biomarkers, CK, as I said, is not always increased. Most of the time, CK is normal. It can be high after exercise, but most of the time it's normal. The only exception I would say is the TK2 form of PMM, where CK are frequently high also at rest. Lactic acid is another biomarker that is very important, but again, most of the time in PMM at rest, lactic in blood is normal. It can increase abnormally during the exercise. We have few biomarkers that are coming into the market, but are not really used as a diagnostic test. I mean FGF21 and GDF15, these two biomarkers in blood are frequently impaired and increased in patients with all different forms of mitochondrial disease, not only PMM. Then, of course, the muscle biopsy, but as I said before, don't forget that mitochondrial changes are also present in aging, are present in other neuromuscular diseases, are present in sarcopenia, are present in so many different conditions. So we need to have the genetic testing at the end to confirm the diagnosis. So basically, to keep in mind few important messages as patient or caregiver, you need to have the genetic confirmation to say that you have a PMM, because aspecific changes in the skeletal muscle specimen are observed also in physiological conditions and in other non-mitochondrial conditions. If you have a diagnosis from your mito expert saying that you have a primary mitochondrial disease, this is not synonymous of being affected of primary mitochondrial myopathy, because you may have also muscle symptoms for your mitochondrial disease, but we say that you have a primary mitochondrial myopathy if you only have skeletal muscle symptoms. In mitochondrial disease, unfortunately, we may have multi-system involvement. We have patients with Parkinson's disease, we have patients with epilepsy, we have patients with stroke, we have patients with liver failure. All these patients are affected, of course, by a mitochondrial disorder, but this is not a primary mitochondrial myopathy. You have a primary mitochondrial disease, which is a different story. And this is very important to keep in mind, because I guess we will have time to talk about this, because there are now multiple clinical trials running, thanks God, and many molecules are very interesting. But for now, most of the clinical trials are focusing only on PMM, on primary mitochondrial myopathy. If you have ataxia, epilepsy, stroke-like episodes, cardiomyopathy, severe arrhythmia, you cannot be considered a PMM patient. I think I'm running a little bit late. We still have a lot of challenges here because, as I said, we defined as an international consortium of PMM very recently, a few years ago, and we are going to meet again in November to update our knowledge in this disease, because we still don't know a lot on this PMM. We don't really know the natural history. We don't know exactly the best outcome measures we need to use to understand how the disease progress, how the disease change over time. And this is important not only for the natural history, but also for the new drugs that are coming. In order to say a drug is working, we need to know how the drug is changing the natural history, how the drug is changing the outcome measures that we have to use, So in Italy, just as a message, we are working a lot on PMM. We have already analyzed more than 118 patients in Italy, and these patients were studied from all our territory, and they were also re-evaluated after 12 months in order to see how the disease changed within 12 months. You know, how different is the 6-minute walk test in a patient after 12 months? How different is the fatigue after 12 months in these patients? And all these things are important for the management. So far, and I'm closing in 2 slides, we have few recommendations coming both from the Mitochondrial Medicine Society, but also from European experience. We don't really have, unfortunately, as you know, specific therapy. Sometimes we may use the mitochondrial cocktail, vitamins, CoQ10. The only 2 exceptions where we can do something more is probably, as I say, TK2, which is going to be treated soon, but also sometimes, even though it's very rare, we may have coenzyme Q10 deficiency. In this case, we may supplement CoQ10 at a high dosage, and the patient usually responds. And this is important because, as I said, we are going to have a lot of trials, and I will be happy to comment more on clinical trials if needed. So thank you. I think this is, yes, this is my last slide. I think I will stop sharing the screen, right, Amel?
No, you can leave the
Ah,
the first, or you can, it's up to you. Well, thank you very much. This was very helpful. I hope that people in attendance have learned a little bit more about primary mitochondrial myopathy. I think this is very timely, and I thank the UMDF for trying to organize this. As Dr. Mancuso said, there are so many clinical trials right now running, and clinical trials that have run in the past years who are really focused on primary mitochondrial myopathy. And I just wanted to emphasize one point. As you've heard repeatedly throughout the talk today, things are changing. What we knew about mitochondrial medicine 10 years ago may not hold true anymore in 2024. And what we used to use as methods of diagnosis for myopathy have changed. And the one biggest change has been the switch from using muscle biopsies to using genetic testing. So many of you out there, I know, have had a diagnosis of mitochondrial myopathy in the past based on findings that doctors found on muscle biopsy, and that label has lingered over the years and got passed on. And with what we know today, most of patients who have had that pathology report saying they have a mitochondrial myopathy are probably misdiagnosed and probably have primary mitochondrial disease with muscle involvement, or have many other conditions that have nothing to do with mitochondria. And so I would urge you, if you are still looking for a diagnosis, to really talk to a neuromuscular specialist who has expertise in mitochondrial disease. And one of the ways to do that in the US is to either ask UMDF or other advocacy group. They have a list of all the experts, but you can also visit our mitochondrial care network. It's mitocarenetwork.org, and you can find a list of all the mitochondrial medicine centers in the US, which you can directly contact and make an appointment to be seen. Okay. We have several questions. Some of them we have touched upon a little bit. So, Michelangelo, we have a question about, what do you do if you have muscle involvement? Do you have to worry about anesthesia or damaging medication that might affect your myopathy or your mitochondrial disease even further?
yeah. So this is another very important point. Again, I think, I don't remember when exactly, probably 2-3 years ago, we met with the Americans, with the Europeans, and we went through the so-called drug toxic list that was circulating through the different websites. And so we came out with a publication that was also distributed as a lay summary to the different patient organizations. Regarding the skeletal muscle and drugs in general, there are very, very few drugs that may be dangerous in patients with PMM. And I would say the only one that is not contraindicated, but we should keep in mind that we have a mitochondrial myopathy when we take it, are the statins that sometimes may interfere with the coenzyme Q10 synthesis in the skeletal muscle, and sometimes they can, I would say, make the muscular symptoms worse in some PMM patients. I don't really have other drugs that are absolutely contraindicated in PMM in general, but valproic acid in POLG PMM. The other drugs, I don't see major problems. Regarding the anesthesia, of course, anesthesia is a complex story in PMD in general, in all mitochondrial patients. And of course, the patient with the PMM as well must do anesthesia in centers with experience. It is very important to avoid fasting. It's very important. You can use most of the drugs, including propofol, you can without problems. The only point is that the doctors need to know that you have anesthesia, and we have protocols that are published and distributed that at least in Europe, in Italy, most of our patients have in the smartphone as well. So in case I have to go for an emergency in a hospital where nobody has idea of mitochondrial disease, we can use safely these drugs, etc. But just to summarize, for anesthesia, there are not major drugs which are contraindicated. All drugs are, when you do anesthesia, if you are a mitochondrial patient or not, is an important decision to take and to balance risk and benefits. But I don't have a very contraindicated drug beside propofol for hours. But I don't know, Amel, if you want to add any other drug.
Yes, sure. So I really want to emphasize that for the most, our patients with mitochondrial disease in general and myopathy in particular do very well with anesthesia and any medication that they need. I want to emphasize that when you are in a life-threatening situation or you have a severe infection and you need a certain type of medication, it's always benefit outweighs the risk of any side effect from that medication. You should go ahead. Of course, having a mitochondrial myopathy or a mitochondrial disease does not preclude you from having allergies or side effects like anybody else. We all have certain sensitivities that are unrelated to our mitochondrial diseases or myopathies. So you have to be mindful of that. If you develop side effect, it doesn't necessarily come from the fact that there is a mitochondrial problem in your body, but you could have sensitivities. But for the most, our patients who are followed by experts in mitochondrial disease are provided a letter of anesthesia precaution that they carry with them. And every time they are going to undergo a procedure that would require surgery or some light sedation, we ask them to put us in touch with the surgeon or the person doing the procedure to discuss the perfect setting under which you should be undertaking these procedures. So yeah, but for the most, there shouldn't be any issues with using anesthesia or medication for myopathy. But of course, you have to let everyone know that you have the underlying disease so they can take the precautions needed and necessary. Okay. One more question. So some people are asking about GI problems and functional GI problems when someone has a myopathy. Are these common in mitochondrial myopathy? Are they related to the mitochondrial disease?
Gastrointestinal problems are commonly observed in many mitochondrial disease. In most cases, you don't have a primary mitochondrial myopathy if you have a major gastrointestinal impairment. Most of the time you have multisystem disorder, like in the MELAS, where you have gastrointestinal dysmobility, sometimes acute. You may have a MINGI, where you have severe gastrointestinal impairment and so on. So as I said, I was trying to say, when we talk about mitochondrial diseases, we have a very broad amount of different phenotypes of different organ involvement. But when we talk about PMM, usually the patient has only impairment of the skeletal muscle. If you have a major impairment on the gastrointestinal apparatus, and if you have a mitochondrial DNA related or a nuclear DNA related variant, you probably have a mitochondrial disease, but most likely you don't have a primary mitochondrial myopathy. But if you have or not a PMM and you have gastrointestinal dysmotility, we don't have a specific pill or specific mito vitamin that works well for the gastrointestinal dysmobility.
Yeah, thank you. Because that was the follow-up question. Are there any supplements that might help with the gastrointestinal problems? And to my knowledge, there aren't really any specific ones. All the supplements that we provide are really there to help enhance the energy level and the fatigue and improve the fatigue level. Okay, another interesting question here about muscle wasting and exercise. Are there any recommended type of exercises to stimulate mitochondrial ATP production, and are there protocols to follow?
Yeah, we should have John Vissing on board, who is one of the, or also Mark Tarnopolsky you have in the States. Yes, exercise usually is recommended in mitochondrial disease. Of course, because it stimulates mitochondrial biogenesis, we say as doctors. The protocol usually is better to have aerobic exercise. I don't really recommend a specific training in my patients, but I do recommend daily aerobic exercise, which can be done in multiple ways. You don't have to go to swim. You don't have to go to any specific gym and spend money for a specific program, I would say. But exercise is very important. You should usually, on the other side, you should avoid, how do you say in English, acute, and I don't know how to say in English, because you cannot stress too much your skeletal muscle, because one of the complications you observe in PMM is, as I say, this myoglobinuria. You may break the muscle if the exercise is too much, it's too intense, too fast. And in that case, the risk is that the mitochondria are not good enough to produce enough energy. And if the entity of this, or the muscle activity is too much, you may break the skeletal fibers and you may have myoglobinuria, you may have damage not only in the muscle, but also in the kidney.
Yeah. I wanted to urge everyone to go on the UMDF website if they want to learn more about exercise and mitochondrial myopathy, because we have so many different presentations and PowerPoints done with Dr. Tarnopolsky, physical therapist, and other neuromuscular specialists who specifically talk about exercise regimen. Sorry. In primary mitochondrial myopathy. But I second what Dr. Mancuso said. Here in the US, we do recommend exercise because studies and science has shown that exercise is really the best way to improve mitochondrial health and enhance energy production in the cell. It kind of acts like a gene therapy with exercise. Exercise causes several signals in the body to be enhanced, and they cause healthy mitochondria to be copied and unhealthy mitochondria to be rid of. And so it really enhances your body's response to making healthier mitochondria. And we always recommend a combination of that cardiovascular or aerobic exercise with strength training. Doesn't have to be every day. It can be 3 times, 2 times a week, whatever you are able to do. And you shouldn't be pushing yourself. The goal is really not to be like the gym person picking weights and lifting for an hour. You can do even 2 minutes if that's all you can do. And with time, as you build up endurance, you can do 5 minutes and then 10 and then 15 and then 30 minutes. The idea is really to keep at it and to keep doing it very seriously and consistently until you get the benefit from it. And it can be counterintuitive because a lot of the patients with PMM have fatigue and lack energy, and they're like, how am I going to do this? I already feel tired. But with time and perseverance, that tiredness is going to start resolving a little bit and be replaced by more energy. So keep at it and find someone to do it maybe with you so they can challenge you and make you more enthusiastic about it. Okay. I have another question, many questions actually, about specific scenarios where genetic testing have found variants, or they have a variant in a gene and it's not clear, or a family member has been diagnosed with a myopathy and should they be tested. So I'm going to try to answer those together. So genetic testing, as you heard, is very important. So everyone, to really make a definitive diagnosis of mitochondrial disease or myopathy in 2024, we really need to find that gene change that can be associated with the symptoms that you are having. Genetic testing comes in many flavors because mitochondrial diseases come in many flavors as well. There are the ones that are maternally inherited that you can only get from your mothers, that are passed on to all the children, but only from females. And then there are the ones that Dr. Mancuso talked about as being Mendelian, which can be transmitted through chromosomes that you can get from mom, dad, or both at the same time. So depending on which disease we are suspecting, we can either just test for mitochondrial DNA that is maternally inherited, or the nuclear DNA from the chromosomes that can be from mom, dad, or both. And sometimes we do both. And sometimes in very specific instances, like the cases that you heard about today that are sporadic, we need sometimes to go get some muscle tissue to test for that mitochondrial DNA deletion in the muscle tissue, because sometimes we cannot find it in the blood, the urine, or the buccal swab or saliva test that we do. So a lot of the time when these genetic test reports come back, they can be very confusing to the non-geneticist. And it's not just with patients and family members. Even doctors who are not used to reading these can be very confused and can misinterpret them. So the fact that the report says there's a variant, it doesn't mean that that is a confirmation of a diagnosis. We really have to find a change in the DNA that is well known and well linked to the symptoms that you have. So having all these variants, or having one variant in a gene where you're supposed to have 2 variants to express the disease, does not confirm the diagnosis necessarily. And that's why it's very important, if you have such a report, or if you still feel confused or don't understand what's going on with your report and whether you truly have a primary mitochondrial myopathy or not, to talk to a geneticist, a genetic counselor, or a mitochondrial disease expert to go over that report with you. Even if the report has been done, the genetic test has been ordered by a doctor, not every doctor who order these tests are expert in genetics report review and interpretation. So in doubt, always reach out to a geneticist and try to talk through the report that you have. And other than that, we cannot really give specifics on a case-to-case by basis without having seen the patient and evaluated the history, the family history, and have seen the report itself. So I hope that if you have put in a question like this in the chat, that you would go back and talk to your primary care and have a referral to a geneticist. Okay. So what else do we have here? So we have an interesting question, and I'm really curious to see how you answer this. So consider an individual that has a mutation that is commonly associated with Leber hereditary optic neuropathy. If they do not have classic vision issues, and if they do have the symptoms described here as indicative of a primary mitochondrial myopathy, would you consider them as having a PMM?
Yeah, I mean, yeah, that's an interesting question because you know probably that in very few cases you may have LHON plus. There were reports of showing brain abnormalities, for instance, in patients with LHON. There are few patients with Parkinson's disease associated with LHON. So very rarely, extremely rarely, we estimate less than 5% of the cases, we may have LHON plus presentation in LHON. But when we talk about LHON plus presentation, this means that you must have LHON plus something else. If you have one of the Leber mutation, but without problems in your vision, which thanks God is not so rare in LHON, you know, the penetrance of the disease is low, especially in female. The fact that you have a LHON mutation and exercise intolerance is very tricky to say if this is caused by the LHON mitochondrial DNA mutation, honestly. I'm not sure it's related, but it's a very interesting question. We should start collecting this information because usually when we say you have a LHON plus presentation, you may have muscle involvement, but you must have optic neuropathy manifest. I guess in the patient you have some skeletal muscle symptom, but not optic neuropathy in this case. So it's very tricky as a question. You're right, Amel, but I don't think if you have a 1111 748 mutation, for instance, and exercise intolerance, I don't think it's caused by the complex 5 variant in the patient.
Yeah, and that brings up a good point to talk about as well. I also don't think that there would be a correlation between a Leber hereditary optic neuropathy known mutation and symptoms of exercise intolerance, fatigue, or muscle pain or discomfort. These Leber mutation can be very common in the general population, and just because one has a mutation, it doesn't necessarily mean that that mutation is going to express itself and cause human disease. In fact, we all have these mutations in our DNA. We all have at least 12 of them, and not everyone develops disease from them. So we genuinely, and Dr. Mancuso and I, we have several patients who carry even the 3243 mutation that can cause MELAS. They carry that and they never develop any symptoms from it, or they may develop very, very tiny symptoms from it that may never come to the attention to their doctor. So we have to be very careful, again, when we look at these genetic reports or when we know of a family history of a certain mutation that can cause a mitochondrial disease, to not always conflate the symptoms that one is expressing with the presence of that change in the DNA, because they may be both true, but they may be unrelated. And so that's what makes our job much more difficult, because we still don't have tools that can give us with 100% certainty that a specific DNA change is causing a specific symptom. And until we have that, we are all going to be living in this gray area where we have to use our best judgment as doctors as to whether or not these are related or not. Sometimes we get it right, sometimes we get it wrong, but we are learning and trying to improve, and that's why we're doing all these studies and all that we encourage everyone to participate in. Okay, so what else? There is a question about preload insufficiency as a symptom of primary mitochondrial myopathy.
Say it again, sorry.
Do you see preload insufficiency, so cardiac preload insufficiency, as a symptom in many patients with primary mitochondrial myopathy?
Not that I'm aware. I mean, usually you may have some deconditioning, but I don't really see any kind of heart involvement in this patient. If they do develop heart involvement, I change the phenotype classification of my patient.
Yeah, so I can maybe answer this question because I know where this patient is coming from. I don't know this patient, but I can tell you my experience seeing adults. So again, this goes back to that label of PMM that a lot of patients are getting just because they have these symptoms sometimes of just exercise intolerance and fatigue and muscle complaints. And sometimes they get the muscle biopsy and they have mitochondrial abnormality, which sometimes can be also called cytopathy or mitochondrial dysfunction. And a lot of these patients have something called autonomic dysfunction or dysautonomia. And one of the symptoms of dysautonomia is preload insufficiency or preload failure. So the whole thing, the whole cause of these symptoms can be just a failure of the body to return enough blood supply to the heart. And so there is not enough blood coming out from the heart and going into the muscle, the peripheral muscle, the skeletal muscle. So when someone with dysautonomia would exercise, their muscles will need more oxygen during exercise, are not getting enough of that oxygen. And so they feel the same symptoms someone with the mitochondrial myopathy might feel, but the reason why they are feeling them is not because their mitochondria is not working, it's just because of the physiology of their autonomic problems. Their mitochondria is not getting enough oxygen to produce energy. And so these patients are very often mistaken for patients with PMM. And I think that's where the confusion is. So I would just make sure you go back to your doctor and try to make more sense of what the symptoms are and whether they are dysautonomia related or truly myopathy related. But I agree with you, if there is no heart involvement, and if it's a pure myopathy, there shouldn't be dysautonomia severe enough to cause preload failure. Okay. So we have several questions about whether Lee syndrome is a PMM, whether a mitochondrial dysfunction is PMM, whether the difference between PMM and other mitochondrial diseases such as MELAS, MRF, CPEO, and Kern-Sears. You touched a little bit on this during your presentation, but can you be more clear in terms of the differences?
Yes, I was also reading the very last question from Hope. Yeah, I mean, maybe I didn't explain this very important point in an easy way. I've tried to repeat in a simplistic way as suggested. Basically, when we have a mitochondrial disease, because the mitochondria are everywhere, from the brain to the knee, everywhere, we may theoretically have all possible organs damaged. You may have all the possible symptoms, all the possible signs. This is because the mitochondria are everywhere. If you have a damage in the mitochondrion, you may have a damage everywhere. The point is that if you have a PMM, if we have a primary mitochondrial myopathy, we only have clinical manifestation affecting the skeletal muscle, the muscles in general. So when we talk about PMM, primary mitochondrial myopathy, the only organ affected is the muscle. You will not have any stroke. You will not have epilepsy. You will not have whatever other organ manifestation, okay? If you have a disease which is considered by your doctor affecting not only the skeletal muscle because you have muscle pain, exercise intolerance, but you also have cerebellar ataxia, you have problems with hearing loss, you have arrhythmia, you have Parkinsonism, In this case, you still have a mitochondrial disease, but this is a multi-system disease because you have at the same time a manifestation of dysfunction in the muscles, but also in the brain, in the heart.
Go ahead.
Oh, sorry. Oh, the screen was changing. Okay. So in this, so basically at the end, you have a multi-system manifestation. Multiple organs are affected. In this case, we define the disease as MELAS, MERF, multi-system mitochondrial disease. We define PMM only if your symptoms are at the skeletal muscle. Otherwise, it's a multi-system disease. It's another form of mitochondrial disease.
Okay, I think we are 1 minute past the hour. Sorry, my picture's frozen. My computer is freezing. But thank you very much, Michelangelo, and thank you for everyone who came, and thank you for the UMDF for organizing this. There are a few more questions on the question and answer board that we will try to answer by writing, and I'll give it back to Kara.
And so I just want to let everyone know that next month, on February 28th at 7 p.m. at our typical Ask the Mito Doc time, we're going to have a talk about ICU and anesthesia management and mitochondrial disease. So mark your calendars. We hope to see you all there. I will leave this going for a few more minutes in case there are more questions that the docs are interested in answering, but thank you for joining us. And if there are any questions that we're unable to get to today, we will attempt to answer them post-event.
Thank you, everyone.